All right. Well, welcome back to Ultrasound Grand Rounds this week. We are nearing the end of our semester and pretty excited. We have a couple more sessions left. We have some really cool talks coming up. But today, I think if you were watching the last few weeks, you were expecting to see someone different. You're expecting to see the one and only, the great Dr. Werner. And she unfortunately was not able to lecture to us today. And so you got to put up with me. So here I am. We're going to talk about some ultrasound for the next hour, and hopefully we'll come away amused, if nothing else, and hopefully some educated a little bit as well. But before we get started, I wanted to tell a little bit of a story, right? So this is a story of a real close friend of ours. My wife and I, we currently live in the house that we live in, but before we moved to this place, we lived in a small little, it was like 1,100 square. No, I think it's like 1,300 square feet. It was really small. Was it 3-bed, 2-bath, Cape Cod? It was just a cute little house. It's our first home that we bought together as a couple when we moved here. After we matched, and it was our residency home and our fellowship home, and eventually, like I said, moved out of it. But it's a really teeny little thing, right? And it had a really teeny little yard. It's about 1/10 of an acre. And so it was, in one sense, it was great. I could mow the thing in about 10 minutes. But the problem is, I like to listen to things while I'm mowing. And so, it doesn't take that long. But that being said, when we lived in that house, we had a dog, right? And that dog tore up the yard. And so my goal was to make that yard look pristine and spectacular. In fact, when I was a resident, one of the attendings, caught me during the middle of the shift. He's like, hey, Matt, check this out. He showed me a picture of his yard, and it was just like the representation of the perfect lawn, like whatever, fertilizing company, did his lawn, right? They could use a picture of his lawn, and it was like the representative picture of, like, you use our products and you'll get this, right? And so my whole goal while I lived at that house was to have a yard that looked like that attendings. And, unfortunately, because I had that dog and he tore up the yard, that never happened. But as a result, we needed to do a lot of, yard work to try to work on it. And so, we got acquainted with a really good friend, right? And so this is the story about, let me cut over to here, the story of a middle-aged gardener, right? That we used for a period of time while we were living in our old house, right? And so my wife and I were enjoying this gentleman was, was really, really helpful in trying to help me get my yard to be as immaculate as possible. And unfortunately, it never quite got to that point, where I could, call it comparable to the attending that I had while in residency. But, he did his best, right? But as a middle-aged gardener, he got to be a really good friend. And one day, my wife and I were sitting in our kitchen, which is just kind of adjacent to the backyard. There's a little driveway that came around. We could kind of overlook the teeny little backyard. We had the windows open. It was like spring or summer day. It was really pleasant, right? Just kind of chatting and listening. And all of a sudden, I heard something that wasn't quite right. And I looked out the window, and unfortunately, our gardener had collapsed in the yard. And so went out there as an ER doc, initiated resuscitative endeavors on this particular patient. Patient was whisked off to the emergency department, unfortunately succumbed to their illness. And on autopsy, we discovered this. So, yeah, the gardener's my garden hose. I didn't employ anyone. But what I noticed a couple weeks prior is that the gardener had developed a little bit of an aneurysm, right? It's something that we were monitoring, right? We had, got our kind of monitoring studies and kind of keep an eye on things. But this unfortunate gentleman, he spent a lot of long, hard hours out under the sun, right? And probably didn't take care of his health all that well. And developed an aneurysm. And so, unfortunately, one summer day, that thing ruptured, and, the rest is history. We had a ruptured AAA, which was the ultimate demise of my garden hose. Now, interestingly, since this is not a human story, but a story of an inanimate object, we actually got to use some form of replication here. And now I have two hoses. So we splice that out, put two ends in, and I got two hoses out of the deal. So the gardener lives on. But hopefully that's a little bit of an amusing anecdote to just kind of bring us into our initial topic of today and kind of get our minds prepped a little bit, albeit in a little bit of a different way than normal. so we can start thinking about the aorta and how we want to scan and why we might scan this in the emergency department. So the topic of today's conversation is bedside ultrasound of the aorta, right? And as always, well, first off, I didn't put the slide in today, but no disclosures to make pertinent to this topic. And so let's dive into the objectives here. So hopefully by the end of this talk, whether you're listening now live or whether you're listening on the YouTube channel later, hopefully the three things that you'll get out of this talk are the indications for aorta ultrasound. Number two, the sonographic findings of the aorta, right? And number three, discuss some pitfalls that you may run into as you're scanning the aorta to really help us out in trying to maximize our ability to use this study and use this imaging technique for our patients in the emergency department. So with that being said, I want to point you to this article. It's a little bit of an old article. It's about 10 years old now, or just about 10 years old. But this was published in the New England Journal. And I've noticed that over the years, the New England Journal does a really nice job of putting out articles that are good review articles, right? They're not necessarily ED specific, but man, when they do one, they really cover the bases to the point that they're really helpful in the emergency department, right? Or even like if you're an internist, like up on the floors or in the ICUs. But this particular one was about abdominal aortic aneurysms. And it did a really nice job summarizing aortas, right? Abdominal aortic aneurysms, the pathophysiology, risk factors, things like that. When you would want to start screening and working these things up and how you image aneurysms of the aorta. And so I highly recommend that you go to PubMed or just go to the New England Journal, pull up this article and start looking at it because I think this is a really, really helpful complement to the lecture that we're giving today. But that being said, a lot of what we're going to talk about is influenced by this particular article. So we're going to move on to indications of aortic ultrasound, because I think it's going to help us set the stage for when do I need to pull this machine to the bedside and start scanning, and then what specifically am I looking for when I'm there. So as we all know, the abdominal aortic aneurysms can present in a really broad variety of ways, right? Patients could present with abdominal pain or back pain or flank pain, hypotension, dizziness, syncope, cardiac arrest. Like any of these could be a presentation of an abdominal aortic aneurysm. And this is what makes it frustrating, right? And it also what makes it challenging, because while it is certainly highly serious, right? Bad things can happen when you have complications of your aneurysms. It's also decently rare relative to the other things that we see in the department, right? So if you take abdominal pain out and say, what is the differential diagnosis of abdominal pain? There's a lot of other things I'm going to put on that list before I hit the aorta, right? Same thing with, flank pain, right? I'm going to put like renal stones there. I'm going to put, some other, urinary obstruction. I'm going to put like pyelonephritis, like all things that are there. We've talked about these on this forum, maybe in front of the aorta, at least on my initial cursory, differential. But it's important to say that the abdominal aortic aneurysm can present in all these ways. And so they ought to be on your differential. And so one of my favorite techniques as an attending now, when I'm staffing with residents is particularly new residents, the interns and maybe early seconds, is to say, okay, you are presenting with this complaint, right? They give me a nice story. Let's say it's the perfect presentation, right? Where they give me the chief complaint, followed by a brief history, followed by a one-line summary of the vitals, a couple line summary of the exam. They say, here's the few things I'm concerned about, and this is what I'd like to do, right? That's the perfect presentation. One thing I'll oftentimes do is say, okay, with this presentation, tell me the top 5 things you're worried about, right? And they'll do that, and they'll say, all right, give me 5 more. And like, oh boy. And they'll like scratch out a few more. And if they get that, I'll say, okay, give me 5 more. And I'll kind of push them until they really can't get any more. And because what I really want to do is, number one, illustrate that there's a lot of things that could be going on and you can't just narrowly focus your attention too early, right? And number two, I want them to get to the point where they've said the word aorta, right? And if we got to go through 10, 15, 20 differentials before they say the word aorta, then we're going to do it, right? Because I want them to kind of constantly be thinking about this when we present patients with abdominal pain, back pain, or flank pain, things like that, right? So that's kind of one of the clinical things that will get you into that. I guess the next question is, okay, not all patients with back pain, abdominal pain, flank pain have aortic etiologies. And so we need to risk stratify, right? That's the, what the rest of the residency training and what the rest of your career is going to help hone is like doing that really good risk stratification. And so as we think about risk factors for the aorta, we think through things like, is their age over 50? Are they, chronically hypertensive? Do they have a smoking history? And then particularly, do they have a family history of abdominal aortic aneurysms? All of these things increase one's risk for pathology of the aorta. And so one of the things that I typically do with the patients that I see and the residents that I work with is say, okay, you coming in with a complaint of back pain. Okay, we've thought about the aorta, right? If you start fitting some of these criteria, then we have to think about it a little bit more and start looking back like, okay, can I justifiably say the aorta is not a factor here based on previous imaging or based on other factors? Or is this something that's going to rise up to the level of concern where now all of a sudden I need to start imaging the thing, right? So, that's going to help us risk stratify. Now, some interesting statistics about aneurysms to begin with. Generally, the classic exam presentation is they present with this palpable abdominal mass, right? And we talk about that in medical school. And, when you have the thing, right, you're like, oh, great, you got to go see this palpable abdominal mass, right? This is like highly interesting. Well, the reality is this is the vast minority of the patients who present with aortas or AAAs have this abdominal mass, right? About 18% of patients will have this palpable mass. Interestingly, the vast majority of patients, when they rupture, don't do well, right? Which is why we want to identify this before they rupture, right? The vast majority of, ruptured AAAs will present with something like back pain or belly pain, right? So a lot of interesting things that kind of set the stage and really stack the cards against us as we're trying to identify this thing for the patients that we're caring for, right? Now, the other interesting statistical thing is, okay, great, Matt, you said I found this thing, and we'll define the, an aortic aneurysm later, right? But it is just barely in the criteria of being an aneurysm. Is this a 5-alarm fire, right? And the reality or the answer to the question is, it really depends on the size, right? And so, according to the paper that we started off with, statistically speaking, if you have an aneurysm greater than about 5.5 centimeters, there's about a 1%. If it's less than 5.5 centimeters, there's less than a 1% incidence of rupture per year, right? And once you hit that 5.5 centimeter mark, there's a huge inflection point to where the risk of rupture is pretty high on an annual basis, right? And so we'll see some aneurysms later on in this talk where they're 5, 6, 7 centimeters or more, right? And so then you can say, okay, based on this graph, right, the risk of rupture ranges anywhere from like 10 to over 30% per year for this patient. And so when you see these patients, if they're greater than 5.5 centimeters, then this becomes your 5-alarm fire versus if they're less than 5 centimeters. Not saying you ignore them entirely, but it's less of a concern than if they were larger, right? So moving on, let's talk a little bit about the normal findings of the aortic, right? Because now we've set the stage, we have to understand, okay, what is the normal thing we're going to look at before we really can make sense of this thing that we're going to say is abnormal. Like you look at abnormal, like, I don't know what's that supposed to look like. Well, that's why we wanted to look at the normals, right? So just from a big picture perspective, the abdominal aorta anatomy. So these images are from the Complete Anatomy app that they've got, so it's really great. We've talked about it before. You can get some 3-dimensional modeling of the body and the anatomy and kind of see how things fit together. So it's kind of a virtual cadaver lab experience. It's made for your computer, your portable devices. But anyway, the aorta itself is a retroperitoneal structure, right? It generally is considered to extend from the diaphragm, right? At least the abdominal component of it extends from the diaphragm down to the bifurcation, right? And it doesn't mean that it just ceases to exist. It just changes names above the diaphragm and below the bifurcation. It's the thoracic aorta above the diaphragm, and below the bifurcation, it's the iliac arteries, right? But in this space between the iliacs and between the diaphragm is this entity that we call the abdominal aorta, right? And that's the real estate that we really want to be closely attentive to as we are scanning our patients, right? Now, typically speaking, unless you have some inverted anatomy. Typically speaking, the aorta lives to the left of the spine. And so I think for most people, as you're setting your kind of getting your bearings or getting your landmarks set when you're scanning, if you look left of the spine, that's probably the aorta. And then we're going to show some ways of confirming. But that's just generally kind of how you're going to find that thing arranged, right? Now, the aorta itself has three major branches, actually four major branches that we want to be aware of, three of which actually two of which we'll be seeing here, on our ultrasounds. But if you go to the cephalad component of the aorta, like the most superior portion or the portion closest to the diaphragm, we're going to start off with a celiac trunk, right? And so you can see that at the top of the image, it's basically this branch that comes off and then immediately bifurcates into the splenic artery and the hepatic artery. We'll show some ultrasound images here in a minute. And then you scan down a couple centimeters below that, and we're going to get to what's called the superior mesenteric artery. So it's one of the first arteries that supplies the gut. And then off to the sides, somewhere within a centimeter or two of the SMA, is going to be your lateral renal artery. So you have a left renal artery and a right renal artery. Those can be seen on ultrasound, but depending on your cut on the ultrasound, you may or may not see those kind of based on how the ultrasound's projected. And then finally, if you scroll down or scan down to the bottom of this image, you're going to run into what's called the inferior mesenteric artery, or IMA. It's going to, supply the rest of that splanchnic circulation. And this one's typically not seen on ultrasound. We typically don't look for it. So the key structures that we're going to look for on our ultrasound, obviously, is the aorta, but then we're going to look for the celiac trunk to get ourselves in the neighborhood of the proximal aorta, the SMA to get us in the neighborhood of the mid aorta, and then we'll scan down to bifurcation to get us to the area of the distal aorta, right? The aorta itself, I guess is slightly dependent. The length is slightly dependent on your body habitus, how tall you are. If for people who are older, it tends to become a little bit more tortuous than straight. But it's in that range of 10 to 20 centimeters long. I really don't care how long the thing is. I don't scan the length of the thing, but that's what it is. But what I do care about is the diameter, right? Because that diameter of less than 3 centimeters is what's considered to be normal. So once we get above 3 centimeters, then by definition, the patient has an abdominal aortic aneurysm. And as we talked about just a few minutes ago, like, how much above that 3 centimeter mark really depends on how highly concerned you ought to be regarding this patient's presentation and whether or not the aorta is at play when it comes to scanning this patient, right? So 3 centimeter diameter. And then when we get to the iliac vessels, we're looking at a diameter should be in the neighborhood of about 1.5 centimeters or less. And so if you have something that's larger than that, then you have to be concerned about an iliac artery aneurysm, right? So that's your normal aorta. Let's change gears a little bit and let's talk about what we should expect to see on ultrasound, like what the normal sonographic appearance of the aorta should look like. And with that, we'll start off with a little bit of a cartoon that I kind of created for this lecture. I thought it was pretty good. A little bit of art from Keynote. But anyway, when we scan in long axis, right, we're looking for something that approximates a black tube. Right. So we know from our previous experience and previous lectures that vascular structures tend to be anechoic, right? Because you have blood moving through them. So it doesn't return echoes back to the probe. Now, if you have slow and sluggish flow, I get it, right? You can see some of that sometimes. But generally speaking, particularly for arterial structures, it tends to be anechoic tubes, right? And in long axis to that vascular structure, it tends to be a line, like a tube, right? And short axis is going to be round, right? And so what we're going to expect to see is this anechoic linear structure that will be the aorta, right? And then two branches that come off anteriorly. The cephalad branch is going to be the celiac trunk, and the caudad trunk or branch is going to be the SMA, or the superior mesenteric artery. And I know I like to kind of correlate things in my mind with what it might look like. And so to me, like if I squint and look at it just funny, it looks like one of those old steamliner ships, right? My son has been into the Titanic lately. We have a book at home. He's been thumbing through that. And so he drew a picture of the Titanic. And it has, the long ship and the smokestacks, and then kind of the really classic pictures of the steamliners. You see them in the ocean, and there's kind of this plume of smoke coming from the smokestacks in the middle of in the midship. So anyway, that's the kind of the midship smokestack steamliner sign, I suppose, in this one. So if we switch over to the ultrasound view here, that anechoic tube is the aorta, right? And as we kind of fan back and forth, we can see two trunks that are coming off. The SMA is the one that kind of goes up and goes towards the right-hand side of the screen. And the celiac trunk, we kind of scan through, it's going to be just immediately cephalad to that SMA trunk, right? And so that's going to be our aorta, right? Or the proximal mid aorta, right? As we scan further down, what we're going to expect to see is the aorta kind of tapers down into a little bit of a narrower point. We'll see as it kind of comes up over the pelvic ridge, it's going to go up and then kind of shoot down a little bit. And then it'll branch into the iliac arteries. And this is going to be the classic kind of off to the side shot. We like to get this one just to show, the iliac bifurcation, but it's essentially the aorta bifurcating into the iliac arteries. And so here we have it kind of coming in from the left is the cephalad, and it goes to the right, and you can see that bifurcation, that Y bifurcation of the iliac arteries, right? Now, the other way to scan, and we need to scan both ways, right? Because two views is one view essentially, and one view is no views, is looking at it in transverse, right? And so if we go back up to the proximal aorta, right, what we should expect to see is we should expect to see a round aorta with its partner vein, the IVC, next to it. And then coming off the aorta, we should see the celiac trunk branching into the splenic and the hepatic arteries. And this is what we classically call the seagull sign, right? Because it looks like a seagull that's flying, in your ultrasound image, right? So the hepatic artery is going to be going off to the patient's left, or it's not the patient's left, the patient's right, which would be the screen left. And the splenic artery will going off to the patient's left-hand side, screen right. So sonographically, here it is. You can see kind of, this one's a little bit tortuous, so it kind of comes off and loops back. And then you can see as we scan through some of those branches, as you can see the splenic artery heading to the right, and then the hepatic artery kind of heading to the left. We don't catch it all in one view here. You have to kind of fan through it to catch it, but it's definitely that bifurcation of that celiac trunk, right? And not far from there, if we scan down just a couple centimeters, we're going to get to really where all the meat and potatoes of this aortic scan happens, right? And this is going to be the area of the SMA. It's quite a busy place. I remember when I was a fellow, just trying to demystify this for myself. And I was sitting down in our office with my Netter's textbook in one hand, ultrasound probe in the other hand, scanning myself and just like, okay, I should expect to see this vein. Where is it? I should expect to see this artery. Where is it? And really scanning. And so what I came up with is it's kind of a layers thing or a sandwich thing, right? So you obviously have the aorta and the SMA, right? Your two cross-sectional vessels here. And then there's the SMA is sandwiched in between the left renal vein and the splenic vein, right? And if you think about it, at this point, there's you obviously have the arterial supply, but then you have all your venous return, right? And so the spleen has a major vascular supply, right? And it's got to return blood from the spleen back towards the heart eventually, right? And same thing with the kidney. It lives on the other side, the left side of the body. So that also has to cross the aorta and get back towards the venous collection point and get back towards the heart, right? Now, interestingly, think through not the etiology, but the function of each of these things, right? The kidney is filtering the blood. And so it's going to return kind of blood that's filtered back to circulation. And so that one, since it's kind of been filtered already, can go back directly into systemic circulation. So it dumps right into the IVC. The spleen is also a filter, right? And that the venous return from the spleen dumps into the kind of the splanchnic return, right? So you have your mesenteric drainage, right? The mesenteric veins from the intestines, right? We absorbed all this stuff that we ate. That needs to be filtered. The stuff that the spleen is dumping back, that joins the intestinal return and forms the portal system, right? And that portal system then goes into the liver for a final filtration before it gets into the systemic circulation, right? And so what we see here, the splenic vein, you can see on the right-hand side of the screen, it returns from the spleen to the portal splenic confluence. And we can see that on our image. And then the left renal vein returns to the IVC. And we can follow these vessels kind of as we scan sonographically. So with that being said, let's move over to here. The arrow here is denoting the SMA. So the big vessel deep to that is going to be the aorta, right? You can see a thin wisp of vessel between the aorta and the SMA, and that's going to be our left renal vein. You can almost see it connecting up to the IVC right there. And then above it, you can see kind of as we kind of scan, we'll see this linear vein appear and then disappear above the SMA. And that's going to be the splenic vein as it heads towards the splenic, the portosplenic confluence, just to our left of the SMA, right? And so that's the main area of things that you have to really be careful and identify your structures as you're trying to scan through here and figure out what you're scanning, right? Be very mindful of the sandwiching, nature of this anatomy. And finally, as we scan further down, right, we're going to go more distal. It becomes simple again, where we have the artery that splits, the aorta splits into the left and right iliac arteries, and you'll have the IVC there as well, and that eventually splits. And then we just have these smaller vessels that we follow. And so here's an example of splitting into the left and right iliac arteries right there, right? And so that's kind of the getting all those different windows and scanning those different places is going to be the place, or the different windows that we want to identify and save and capture for this study that we're going to be doing, right? So that's normal. Let's talk for a few minutes about what pathologic looks like, and then we'll kind of finish the thing off with a little bit of pitfalls, right? So there's two major findings for a AAA that we're going to be looking for. The first one is an enlarged diameter of the aorta, right? And the second one is a thrombus with a residual lumen, right? And so let's just stop and talk about the physics for a minute. If you have imagine a balloon, right? And it's in its deflated state, right? There's basically zero wall tension, right? Maybe let's put a little air into it and we have just a teeny bit of wall tension, but there's enough strength in that wall to be able to withstand the wall tension. And so we have a minimally inflated balloon, right? As we inflate that balloon, right, the diameter of that balloon gets bigger, right? And you can imagine the tension on the wall significantly increases, right? And if we blow it up too much, eventually the wall tension will be exceeded by the pressure inside the balloon, and the thing pops and lets all the air out, right? And the same phenomenon happens here with the aorta. There's a certain amount of strength that aortic wall, the exterior wall, can manage. And as we grow that exterior wall, right, there's some more tension that's put on that wall, and it gets big enough that eventually it just ruptures, right? And so that's what we want to avoid. But that's also what's happening from a physics standpoint and what we're going to see here on our ultrasounds. So this is an example of a AAA, right? And obviously it's a lot bigger than 3 centimeters. But what we see here is the part that's illuminated by color is that residual lumen, right? But around it, we see this large rounded thrombus, right? And that thrombus lives inside the outer wall of the aorta, right? And so what we need to be careful is we actually measure from outer wall to outer wall, because that's the true diameter of this abdominal aortic aneurysm, not whatever the residual lumen is. And so this patient has, quite a large one. We can kind of correlate that with the graph on the side, and it looks like it can be somewhere in the neighborhood of 6 or 7 centimeter abdominal aortic aneurysm. We can see a couple more examples of this live. So here's long axis, right? We can basically see you scan down, and all of a sudden we have this significant enlargement of the aorta, right? And you can see some blood flow through that residual lumen, because you obviously have to perfuse through the thing, but there's some thrombus in that wall. And that whole thing is going to be the abdominal aortic aneurysm. And then if we turn cross section here, we can see the same thing as we scan down right there, right? You can see the residual lumen and that large exterior wall. And I think this is a good place to kind of pause and say, okay, now the question becomes, okay, you show me what that looks like. It's pretty simple. It's a tube that's got a big thrombus in it and it's bigger than it ought to be. Where do these things typically live? And so, I mean, they can be theoretically anywhere along the aorta, but the vast majority of them are going to be infrarenal, right? Below the renal arteries. And this is why we want to really be careful with identifying our landmarks, because you need to identify where the top thing or top of this abdominal aortic aneurysm is as you're going to be communicating with your vascular surgeon. So we talked about how the SMA takeoff happens anteriorly on the aorta, and then within a centimeter or so of the SMA is going to be your lateral renal vessels, right? Your renal artery and or left and right renal arteries. So the question you need to ask yourself is, where is this AAA in reference to my SMA, right? Am I below the SMA, in which case it's probably an infrarenal aneurysm, or am I above the SMA, in which case it's probably at least a portion of it is a suprarenal aneurysm. And that's going to be some important information that really doesn't affect a lot for us in terms of the physics and morbidity and mortality, but it affects a lot for the operative management of these patients, right? So back to kind of what we're talking about, here's another example of a 6 centimeter AAA. You can see a very nice residual lumen. And if you're not careful, you can put your probe in there like, oh, that looks pretty normal. And you measure that anechoic space, completely ignoring the rest of the aneurysm around it. And so you got to be really, really careful as you're scanning these patients. Here's a long axis view where you can see just a nice fusiform infrarenal AAA, where the baseline diameter of the aorta is about 2.5 centimeters, but the whole thing is about 6 centimeters in diameter. And the same thing, just scanning down just a little bit more. And if you want one more example, here we go. So here's another example of just an 11 centimeter abdominal aortic aneurysm, right? So let's talk for a few minutes about how we scan this. How do we protocol this? What images do we save? So basically, you want to approach the patient, right? Have the patient laying supine. It's probably going to be one of your easiest, well, it's going to be the position you find them, but one of your easiest positions. Put the transducer in the midline of the abdomen and scan from the xiphoid to the umbilicus, right? You're going to do this with the curvilinear transducer. And as always, you want to select the preset that most closely approximates the study that you're doing, right? And so since we're scanning the aortas, you want to select the aorta preset. Now, the question that people ask is, do I scan transverse first or do I scan sagittal first? And that's really entirely up to you, right? That's preference. I think if I got to remember here for what I do, I think I scan transverse first, mostly because I like to see the surrounding anatomy, kind of get my landmarks, and then kind of hone in on the aorta itself. And so this will oftentimes be the first image that I see somewhere in the mid-abdomen, where I'm looking for a couple key structures. The first one is the vertebral body, right? It's going to be this hyperechoic inverted U with a shadow that's going to be deep to that, right? Because that's going to be the very back or deep end of the scan that I'm doing. If I see too much vertebral body, or the vertebral body is way too high on the screen, I just am wasting so much space. I want to put that vertebral body at the very bottom of my image, right? And then above that are going to be two vessels, the aorta and the IVC, which are labeled here, right? And if I can put those somewhere in the middle, that's most ideal. And so I think this is a helpful way of doing it, looking for the vertebral body as your key landmark. Because I've seen a lot of people, providers who scanned and they found a vessel and they say, hey, look, I found the aorta, only to have done a beautiful scan of the SMA, and then the aorta is deep to that. And so if you start deep, you find your vertebral body, place that at the bottom of your screen, and then adjust everything accordingly. I think that's really helpful in terms of getting your key landmarks and then adjusting your key landmarks to match the image that you're trying to create, right? And so that's what we're going to do. We're going to start there. Generally, I'll start in the neighborhood of the SMA and then move up to the proximal, scan SMA, and then scan distal, right? To get 3 views in the short axis orientation, right? Followed by doing it in long axis, where I'm going to find essentially the elongated tube of the aorta with that steamship sign, right? The SMA and the celiac trunk, right? And it's really key to find these two vessels as your key landmarks, because it's very easy to find an elongated vessel, but be on the wrong one, to be on the IVC. And to say, hey, the aorta looks fine, but you actually were scanning the IVC. So you really want to be very closely attentive to your vessel and make sure you have these 2 branches that come off your aorta as you're scanning, right? And so we mentioned the 3 transverse oriented images. The first one is going to be this proximal, where you look for that celiac trunk. You look for that seagull sign. We can see this one looks like a kind of a mutated seagull, but you can see the trunk with kind of the splenic vessel off to the patient's left, the hepatic artery off to the patient's right. Here's another example of the celiac trunk, where you can see kind of it coming off. This is the one we showed earlier, where it's a tortuous celiac trunk, but it does split off. And then if we scan down a couple centimeters, we get to that SMA, right? And again, the arrow is pointing to the SMA. You can see the aorta. You actually see some of the renal vessels taken off the aorta, as well as that left renal vein between the SMA and the aorta, right? And we've shown pictures of the distal portion where it just bifurcates into two, and so I won't repeat that one. So with the few minutes that we have remaining, what I'd like to do is talk about a few pitfalls as we scan, just as a recap here. Remind you, we talked about some of the indications why you'd want to scan. It's a very broad list of indications. We talked a little bit about the aorta, and it's a 3 centimeter or less tube that goes from the diaphragm to the iliacs. And as we scan that, we are looking for these very specific landmarks, and anything that has an outer diameter greater than 3 centimeters should be considered an aneurysm, with specific attention to, ones that are greater than 5.5 centimeters, making sure we include that thrombus in the residual lumen. So all that's pretty basic, straightforward, but then where it gets difficult is in the fact that sometimes patients like to throw you a little bit of a curveball, right? Or sometimes we set ourselves up for failure with inappropriate machine settings. So the first one is, again, I was telling you about inappropriate depth. So here we start really, really deep. We can bring it down into something more appropriate right about here, where you can see that hyperechoic inverted U kind of towards the bottom of the screen at that shadow. And in the original clip, the deep clip, you can see it's way up at the top. And as we adjust our depth, we can bring that down. And now the vessel immediately above that, right, that large vessel is going to be your aorta, right, with that kind of that flattened IVC just off to your left patient's right. So that's the first pitfall. Just make sure you've got your machine set up to set you up for success, right? Make sure that whatever the problems you may encounter, it's not you, right? If you got your right preset, right, you adjust your depth, everything's good to go, right? The second pitfall is scanning the wrong vessel. And we talked about this one a little bit, but here's an example of the IVC, and you can see how they look very, very similar to the IVC looks very, very similar to the aorta, in that it's a anechoic tube. There's even a small degree of pulsatility to it. But what's different is it does not have those, the SMA and the celiac trunk taking off from it, right? You will not have those branches on the IVC, right? A couple of little tricks that I found, I don't have it imaged here, but just as kind of a little bonus material here. A couple tricks that I found that's helpful is if you tilt your probe up and look towards the heart, sometimes you can even see the IVC dumping right into the heart, right? And that's not a view that you'll have of the aorta, because remember, the aorta comes out of the heart from above, right? So it loops over the aortic arch and then travels behind the heart kind of as it comes down in through the thorax and into the abdomen. So you will not find from the abdomen an image of the aorta entering the heart, right? But you will find that of the IVC dumping directly into the heart, right? So if you can see a vessel going into the heart, that's the IVC, right? The other thing that I found to be helpful is looking for the right renal artery. So just like the left renal vein has to flop over the aorta to get to the IVC to kind of complete its path, the right renal artery has to somehow get from the left-hand side past the IVC to the right kidney. And unlike its venous counterpart, it does not go over the IVC, it goes under the IVC, right? And so excluding the azygous system, right, the right renal artery is the only vessel that you will see sonographically that travels deep to or posterior to the IVC. And again, I don't see it here. Maybe I'll make a YouTube short about it. But it is, if you see a vessel traveling in cross section underneath the IVC, that is going to be a good indicator that you're looking at the IVC, right? So those are, the main finding, two little bonus findings, right? To make sure we're scanning the right vessel. The next pitfall is not scanning the thrombus, right? If you're kind of lazy and kind of look and say, oh, there's an anechoic thing, let's measure that, right? That looks pretty normal. We can approximate that over on the scale on the other side. We're looking at something that's about 3 centimeters, maybe 3.1, 3.2, something like that. But that would be wrong. If you're scanning this or measuring this and calling it the aorta, that would be wrong, right? The aorta, the adventitia of the aorta goes around this whole structure, right? Thrombus included. And so to accurately measure this thing, you need to include the thrombus. That would be an appropriate measurement and give us a little bit better estimate of what this patient's actual aorta size looks like. right? And the final pitfall that I want to talk about is bowel gas. And this is going to be the big one that you run up against all the time. It's going to be really, really super duper frustrating. As you're scanning, you're going to be like, I can't see the aorta, right? It's just, maybe it peeks out here and there. We saw it right there, it peeks out. But sometimes you're just not going to be able to see it very well. And there's a few techniques you can try, right? You can, apply a little pressure, wait a little bit of time, see if you can kind of part that curtain as you get peristalsis, moving the gas through the bowels. Perhaps you can roll the patient and kind of try to get underneath the air. Kind of if you roll them and kind of and scan underneath the air, looking back at the aorta, that may help. But sometimes you just can't get it, right? For whatever reason, the air is just not cooperating with you, in which case you get the best information that you have, because that's better than no information. But just like, other things, you have to realize the limitations of what you're doing. It's that if you don't completely visualize the aorta, you can't say completely that there's no abdominal aortic aneurysm. Maybe if you say I missed a centimeter or two, you can surmise that there's likely not something there. But you have to take that into your clinical context of, I didn't see everything. This is technically it's an indeterminate study, but what I did see, here's the results, right? So that's going to be one of the pitfalls that you may encounter. So as we wrap this thing up, couple key points to remember, maybe takeaways, for this lecture is, number one, the aorta is generally going to be left of center. You can create some scenarios where they have total situs inversus, and it's not going to be the case, but generally it's left of center. You want to be very, very picky and very, very careful that you identify your landmarks, right? Both to make sure that you're scanning on the aorta, but also identify the three main branches, or look for the main branches of the aorta, to get yourself oriented where you are in the abdomen, not just that you're on the right vessel. Again, reminder, the normal aorta is less than 3 centimeters. So anything above that is technically, by definition, aortic aneurysm. And then you can use that scale that we use to kind of grade the severity and what degree of risk that this patient has for rupture, and then kind of downstream effects of what you need to do based on their complaints and what size their aorta is. And finally, anything above that 5.5 centimeter mark, high risk for rupture on an annual basis. And so if they're presenting with any symptoms that could be referable to their aorta, and they have that greater than 5 centimeter AAA, that needs to be investigated while the patient's in the department. You have some explaining to do in terms of, what the patient's pain is being caused by.